ECG. Basically, it's a teaching case, right? So now you have to keep your role in mind that you're a junior doctor. So you're not a consultant, you're a junior doctor. So what are the basic important things for you to know about ECG, and what are the basic important things for the person in the other role to know? Mostly it's nurses for whom it's taught. So for nurses, the most important thing for them to understand is what is PQRST, what is rate, what is rhythm, and the commonest thing and the most detrimental thing is ST elevation out of the rate and rhythm things. Because other things, if you broadly classify, everything comes under rate, rhythm, regular, irregular, under that category, right? So we have to very broadly classify that and very easily communicate it to the person in front of us. And we also have to use really good interperson skills, really good communication in the exam, because it's basically a communication exam. So they care more about how you talk rather than what you talk. But of course, if you're going to go into rubbish details and you're going to discuss things very, very, very in detail, like, this line is 2 mm high and that's 1 mm and that's 3 mm and that's 5 mm, you've lost it already. Or you're going into too much detail, you're not going to get across the case, right? So I'll start with the ECG now, and I hate the interruption with people waiting. So is it possible someone else adds people into the meeting, because I'm constantly adding people? Can anyone else allow people to get added, or is it me who has to do it? Good. Please let the others add the others on the meeting. I'm not going to interrupt myself any further. So with ECG now, you go into the cubicle, you have Samantha who awaits to talk to you. You build a good rapport with Samantha. How do you build a good rapport with Samantha? Hello, Samantha, I am Aisha, one of the junior doctors here. um, how are you? How are you doing? How's your rotation going wherever you are? How's your rotation in the ED going? How's your rotation in medicine or cardiology? Wherever you are placed, you can name that place. How's your rotation going? And how are the nurses with you? How are the doctors with you? Have you faced any challenges at all where you felt you needed more help? So that's like a build up conversation, and it's absolutely normal to have a build up conversation in the exam and like sort of talk to them that, okay, we can be a bit, we can break the whole you're a teacher, I'm a student thing, because we're colleagues here and we can have a natural conversation as well. So I would have started with this and then said, right, so today I've been told that you needed to learn a few things about ECG. And then she'd say yes. And then, of course, what in particular do you want to learn about ECG? So, yeah, doctor, I just wanted to learn about rate rhythm, or maybe can you teach me ST elevations, or maybe can you teach me, for example, I don't know anything. I just need a brief baseline about ECG. So you then tell her that is great, because I know a little bit about ECG, not too much in detail, but I know a few things that are very important and which can broadly classify everything, and we can save a lot of patients if we are familiar with these things. So if she tells you in particular, teach me ST elevation, then you should straight away go to ST elevation first and teach her ST elevation. And if she asks you particularly about other things, then go particularly and go teach her those things. But if she doesn't ask any of those things and she's asking you, just teach me ECG. So I'm going to go with the teach me ECG platform. Okay. So well, with ECG, ECG is the electrocardiograph. It's it's something that catches the electrical activity of the heart on a paper. So there is electrical activity in the heart, which is why the heart constantly pumps blood. And ECG is an evidence of the electrical activity. So there are a few things on ECG, basically just 4 waves that you need to be familiar with. Once you're familiar with that, those 4 waves continue to repeat throughout the ECG. So you open an ECG strip, you might be having an ECG strip, and if you don't have, you'll have a pen and a paper, and you can then start with the ECG there. So what you do is you tell the patient about this section of the ECG. So tell her the best place to learn what is going on with the patient, or if something is wrong with the patient, is to look at the second lead, lead 2. The one at the base, that's a long rhythm strip and it shows everything that's going on with the ECG. So if you see here, we have a P wave here. This P wave indicates that there is depolarization in the atria. And then there is a QRS complex that describes the QRS describes the depolarization in the ventricles. And of course, the ventricles are bigger. So we also have a repolarization wave that is from S to T is a repolarization of the ventricles. Now, yes, I use terms like depolarization and repolarization, and that means when depolarization is happening, after that, the when atrial depolarization happens, the atria contracts after that. And when ventricular depolarization happens, the ventricles contract after that. And repolarization means the opposite. That means they relax. So that's a complete heartbeat for you. In PQRST, that's a complete heartbeat for you. Never say that P means that the atria contracted, QRS means the ventricle contracted, because that's the wrong term. This is electrical activity. This is not responsible for the muscle activity. This indicates what the muscles will do, but basically this is the electrical activity of the heart that's on the paper, right? Having said that, I've told you PQRST. So most of our work is with the P. You need to remember what an R is because half the things are associated with the R's as well. So the next most important thing in ECG for you to know is if something is wrong, and you can find out that easily if there is if you are familiar with how to know the rhythm of the ECG and you know the rate of what you're seeing. Now, rhythm is if the heart is beating regularly or irregularly. It's very easy to measure. You take a strip of paper and you put it on top of two R waves and you mark it, and then you slide that piece of paper across the ECG strip. If the R waves continue to have the same amount of distance from each other, that means the ECG is regular. You don't need to do anything. But if there are spaces and there are lapses, sometimes it's closer, sometimes it's not there, sometimes there is a big gap, that means the heart rate is irregular. And if there is an irregular heart rate, you immediately need to call your senior. That's what you do. So an irregular heart is not good. It's an abnormality in the heart, and you need to call your senior. Are we clear so far? So you have clarified to her PQRS and you've clarified the rhythm part to her as well. Always go first with the rhythm because you can't explain rate without rhythm. So go with the rhythm first. Then you can tell her that am I overwhelming you with information? Is it too much to learn? Because I'm just trying to touch really, really basics so that you can filter out large amount of things. So right, she'd say, yeah, doctor, continue. Okay, let's go to the second one. Now you need to know about the rate. What's the normal heart rate? Ask her the normal heart rate. It's 60 to 100, right? So anything that's below 60 and anything that's above 100, you need to inform your senior or you need to inform your doctor because that is abnormal. So how do we calculate a rate? It's very, very easy. You have to count 30 big boxes. So you count 30 big boxes and you count the number of R waves in that and you multiply that by 10. The number of R waves in 30 big boxes with 10. So for example, you're seeing 30 big boxes and the number of R waves are 7 in those 30 big boxes. That means multiplied by 10, it's 70. So that's a normal heart rate. But if it's 11 R waves in 30 big boxes, that is 110 heart rate, and you need to call your senior immediately. Similarly, if there are 5, you need to call your senior again immediately. So that is about rate and that is about rhythm. Now, the most common thing that we encounter in A&Es or in cardiology units is ST elevations. And you mentioned you wanted to learn that, or if she doesn't mention, please make sure you do teach her ST elevations because they happen suddenly. The patient, the nurse needs to know how to uh, know about ST elevation. So when you're done with that, you're done with a major chunk of ECG, and at the same time, you constantly encourage her. Do I make sense? Am I understandable? Am I too fast for you? Oh, if I'm fast, you can absolutely ask me. I'll slow down, and you can also say in between different lines like, "This is really interesting. Oh my God, I love teaching, and I'm enjoying it so much." You can throw in these points for your interpersonal skills and for good communication skills, right? So now coming to ST elevation, see, like I told you, there is a PQRS and this is a T wave. That's how it should appear normal. And in an ST elevation MI, there's going to be a big elevation of the ST wave and you will see it there. And it's going to be very, very huge. It's going to look like a camel hump, very high. And that is when you need to ring a bell and call emergency and call your seniors because your patient's cardiac tissue is giving up and they're not feeling well and it's a heart attack. After having said all of that, you tell your patient, sorry, you tell the student, do you have any questions for me so far? Did I make sense? Anything at all that you didn't understand, you want me to repeat? Will you be able to pick at least these three things on an ECG, these four things? Well, that's brilliant. Our job is done. And if you need any more help with regards to ECG, please feel free to come directly to me and ask me for help. I'll be happy to facilitate you. She will have some concerns. Maybe she will ask, maybe she will not ask, but basically that's how I would advise anyone to teach ECG in the exam, because you just need to teach her PQRS, rate, rhythm, and ST elevation. If you touch these four spots, you will pass. But if you don't touch these four spots, you will not pass. Also, do not assume. I can assume you don't know ECG. I can assume you are worried about learning ECG. I can see you want to learn ST elevation. No, stop assuming. Talk to her. Listen to her, what part of it she wants to learn. Maybe she knows PQRS, maybe she knows rate and rhythm. She just needs to know ST elevation. Then just teach her ST elevation. And if she says, what other tests can I do? Then tell her about the other tests that she can do. Listening is the most important thing in the exam. If you don't listen to the patient, you lose it. So that is about ECG. Am I clear so far? Any questions in ECG so far? Any questions at all? No questions?
Which four things we have to know? Can you please repeat again?
You need to teach her the PQRS T complexes. You need to teach her these waves. You need to teach her rate. You need to teach her rhythm. And you need to tell her about ST elevation. You have to touch these four things at all costs in the exam. Okay?
Aisha,
Thank you.
hello.
Hello?
Uh, Actually, regarding the ECG, should we say that how the heart is beating, how the PQRS is originating the heart,
No,
is coming from the upper chamber,
no.
lower chamber? No need
No,
that
no,
part,
no,
right?
no, no. Don't no need to go that this is AV node and this is SA node and this is blah blah. Because see, you have 8 minutes. You just need to teach her this is the strip and this is what you need to pick on the strip. That's it. She doesn't need to know the physiology and pathology and blah blah. She needs to know how to read an ECG and when to call the senior. You have to see, like, if she's working in A&E or in a cardiology unit, what is more important for her to know that the SA node is working, or for her to know that the patient has an irregular rhythm? A doctor needs to see the patient. So
Yeah.
that's how you have to classify it.
And regarding the ST elevation, what exactly you have to say?
Well, I have made it very clear. I mean, you can't expect a nurse to understand what an ST elevation is. So I said, see, this is the normal P, QRS, and this is the little t. This is the slightest elevation you can see. But with ST elevation, you'll see a huge spike. You'll be able to see a camel hump when you see an ST elevation. And when you see anything that looks like this, you need to immediately call your senior,
All right.
right?
Okay.
Yeah.
Got it.
Any more questions? Or should we move ahead and do one more and then we'll be done?
Hello.
Hi.
Yeah. So, for example, do we should we mention the QRS complex if it's narrow, why it's narrow, and if it's like wide, why?
No.
No, nothing
No,
about not
because
the
see,
detail.
yes, see, because if you go into the detail, so in a narrow complex tachycardias or broad complex tachycardias, it is
Yeah.
tachycardia anyway. And a nurse doesn't need to know that it's a narrow or a broad complex
Okay.
tachycardia. She just needs to know it's a tachycardia. The senior needs to see the rest. You're not teaching a doctor, you're teaching a
Mm-hmm.
nurse. And a nurse, for a nurse, this is
Mm.
this is it. She doesn't need to know more.
Okay. So just the rhythm.
Yeah, yeah,
Of,
just rhythm and
yeah.
rate and like basic things where she can call a senior, where
Yeah.
she knows it's a red flag and she needs to call a senior.
Yeah. Okay. Yeah. Thank you so much.
Yeah.
And what about the type? Because I heard some people they are mentioning the type of MI. Which type? Because if it's in lead one or in lead two or visual deep.
No, no. So what difference does that
Okay.
make? Does it change any treatment?
No.
So,
No.
does it make a difference? No.
Okay.
So, no.
Okay. Thank you.
Cool. Okay, any other questions? Anything at all you need to ask?
So, Dr. Aisha, so if it is like that, that there is a ST elevation, so what exactly we should say that it is a ST elevation? So you have to immediately inform your senior,
Yeah.
and no need to say that this is a myocardial infarction or something like that. What do you
No,
think?
of course, you're going to tell her that this means this thing indicates that the tissue of the heart is constantly getting injured, the heart is not functioning, it's a heart attack. You need to call your senior. ST elevation means a heart attack unless proven otherwise. You need to call your senior. Regardless if the patient is asymptomatic or symptomatic, you have to ring the bell and you have to call the senior.
Okay, okay.
I have a question, please.
Yes.
What if uh, the one we are going to teach is a medical student, if, not a nurse,
It's not
because
a
he's
medical
fifth
student.
year. He should know, for example, the differences between like type of MI. No,
No, it's not a medical student.
it never come for a medical student.
No, it can't come for a medical student because a
Okay.
medical student has to be taught by his professors, not by a
Mm,
junior.
okay.
Okay? And no, it's not medical students. Don't worry about that. It's always a
Yeah.
nurse.
Okay. Yeah.
Hi, excuse me.
Yeah?
Yeah, I had my exam a couple months ago and I failed that by 1 mark. In that exam, I had the station in which it was a third year medical student that you had to teach ECG.
A third year medical student. So
Yes.
what did you teach him then? Did you teach him broad complex tachycardias or no?
No, no, she was holding an ECG strip and it was ST elevation MI. But I
Right.
passed that station on a 6.
You pass that station on a 6. So if it is a third year medical student, then again, it's not a final year medical student who's dealing with medicine at all. She's doing the baseline, she's in the basics, she's not in the clinicals. I would still advise that this amount of information would be enough for her as well.
Okay,
And
thanks.
at the same time, you have to see, like, you have 8 minutes. This is the maximum you can convey in 8 minutes. This is the maximum GMC expects you to convey in 8 minutes. You can't go behind. It's impossible to go above this. How can you go above this in 8 minutes? The case is not about what you're teaching. The case is more about your communication skills. Are you able to talk to the person? Are you able to make them understand what you're saying? Are you able to emphasize on the importance of all the findings that they see? That's what they're looking at, not at AV nodes and SA nodes and blah, blah, blah. No. Because then ECG is a wide topic. There's a lot of stuff that you will have to teach then. So, no, I would say, even if it's a third year medical student, for any level of medical student, I would say that no, it's best you stay with this technique at regardless of who it is.
Hello, Dr. Aisha.
All right.
All right, sorry, a couple of questions for you, please. So,
Okay.
while we're teaching the student, do you like entertain questions along the line, or you wait till you complete the station?
It's basically your choice. They don't really interrupt you during your consultation while you're talking. They always do it after the second minute bell. But if you like, it's your priority. If you want questions in the middle, good. If you don't want questions in the middle, you tell them any questions you have. We'll answer that in the last 2 minutes. But let me get across with this so you can go with teaching then.
Okay. So, thank you. Another question. At the end of your teaching, do you ask them to like kind of recap what you've taught them or something?
No, that's the worst thing you can do to someone who's not a doctor. Don't do that. Don't do recaps.
Okay.
Because if they tell you, no, I don't know anything, well, you've done a disastrous job anyway. So I wouldn't recommend
Okay
doing
then.
a recap. Yeah.
Okay, but then at the end of the day, you check understanding as you go on, anyways, right?
Yeah. Well, if she tells you that you're giving me a lot of information, that's a sign that you need to stop and you need to tell her, okay, so let us recap what we have done so far. And if you've gotten that, only then will we go ahead. So you just go back. You stop
Oh,
instantly if she says that. Yeah.
all right. Thank you. Thank
You're
you.
welcome. Anything else? Let's go to the next case. Okay. So the next case is cervical smear teaching case. That's a medical student. It's a fourth year medical student or a final year medical student, and he knows what a pelvic exam is, but he needs to know what a cervical smear, uh, why cervical screening is done, what a pap smear is, or the case would be what is uh, it's pelvic exam, PV, per vaginal examination. So let's just stay with PV exam. What's a PV exam? So you go into the cubicle. Again, good manners. Hello, I'm Aisha, one of your colleagues here. Are you the medical student here? How are your rotations going? How are you finding our ward? Have the seniors been helpful? And are you able to learn things on the word? Okay, right. So I've been told that I needed to teach you how to do a PV exam, which is a pelvic exam. But I'm also aware that you've read upon it. Yes, doctor, I know it. I just don't know how to perform it. Well, absolutely don't worry. When I was your age, I wouldn't know it either when I was in fourth year, but my seniors helped me, and here I am helping you today. So let's get going. So the first thing is, why do we do the exam? We do the exam because patient might have some complaints. They might have a discharge, they might have pain, they might have a lesion, anything at all that a patient might have or complaints with regards to the front passage. We go ahead with uh, PV exam basically to see everything clearly. And when we're doing the PV exam, we need to do the inspection, we need to properly expose the patient, we need to follow all the proper protocols. So you first take a nice decent history from your patient for what their complaint is, and you have to make sure that they're not in pain, because if they're in pain you're going to cause a lot of more pain, and that's not advisable to do a PV exam if the patient is complaining of a lot of pain, right? Without a pain medication, you should always give them a pain medication. Then you need to ask the patient about past medical histories, allergies, any medications they're on, and then you have to explain the whole procedure to the patient. So you need to explain why you're doing the procedure and what the procedure is. You need to explain the position to the patient, which position they'll have to lie down in. You need to explain the exposure to the patient, which is below the belly button, and you need to explain to them the position that they're what is it? It's the heel against the hips, and they have to spread their legs on the opposite sides for good visualization. And obviously, do tell the patient that you will have a chaperone throughout the examination with you. Please be respectful because it's a private exam and patients are uncomfortable. So make sure they're comfortable before you proceed with the exam, and talk to them throughout the steps to make them comfortable. That's how I would do it. Now I'm going to go ahead with doing it and show you how it's done. So then you go towards the dummy and you pick a duck's this, what is it called? The duck speculum, I think. You pick up the duck speculum and you teach the patient how it is. You tell him these are the lips of the speculum, this is how it opens, this is how it closes, and this is it's advisable to lubricate it first with an anesthetics to make sure the patient is not in pain. And at that time, when the patient has exposed and they're in that position, you go with it. Like I personally told when I had it in my exam, I told the patient you go with the handle at 3 o'clock in the 3 o'clock direction. But first of all, you need to see any abnormalities that you see, any bleeding, any discharge, any trauma, any lesions, any ulcers at all on inspection. You also need to ask the patient to cuff for you to see if there is any protrusion or any abnormalities with cuff, any stress incontinence, anything at all before you proceed with the procedure. If everything is clear and everything is fine, or everything is not clear, you need to know what you're seeing. It's an ulcer, it's a bruise, it's a mass, it's a lump. What exactly are you seeing? You need to be sure about that. Then you go with a 3 degree for inform the patient, go at 3 o'clock, and then slowly and turn it to a 12 o'clock. And when you turn it 12 o'clock, then you open the speculum very slowly, very gently, and tell the patient that if they feel any pain at any time, they should ask you and you'll stop the procedure, right? When you're doing that, you need to have ample amount of light with you so you can visualize all the structures inside. Once you have done all of that, you need to visualize the sides of the vaginal walls, all of that, and you need to visualize the cervix. So if you can see any abnormality, you need to know the normal anatomy first. So if you see anything abnormal, like you see any lesions, you see any polyps, you see any ulcers, you see any discharge, green, red, yellow, anything at all that is not normal, you take a specimen from that, or you take a swab from that, and you note what you've seen clearly, and then you slowly, without hurting the patient, um, open the screw of the speculum, and then you re take it again in the 3 o'clock position, and then slowly take it out. Once you have taken it out, discard it. See first if there is any blood on it or any stains on it, discard it and help the patient get up in a dignified manner, help them cover themselves up as well. That is very important. Patient privacy, patient's dignity is very important throughout this procedure. So that's basically the speculum exam. Then at the end, when you're done with the exam, he might ask you questions at the 2 minutes. Doctor, what is the most important thing? Or what is the one thing I shouldn't miss? Or what is blah, 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 different questions. So from me, he asked what would be the one thing that I shouldn't miss. I said the most important thing is for you to make sure the patient is not in pain. Make sure you tell the patient that if they see any bleeding, or they bleed a lot profusely after the procedure, they should immediately come to A&E, and you need to tell the patient they might have mild pain, mild discomfort. These are uh, common things that might happen. But what I should have also said was that whatever you found, whatever exam you have done, you need to document everything you noticed throughout the examination, and you need to discuss it with your senior, whatever your findings are. And if you have taken any swabs, you need to chase it and take it to the microbiology lab as well. And that's it basically. That's smear teaching. So I'm constantly throughout the consultation trying to engage with the patient. When I'm doing the teaching, I'm telling him, see, this is how you do it. It's okay, it's the first time and we all make mistakes, but these are the things you should avoid. Patient's dignity, patient's privacy, make sure she's comfortable. These things are very important when you are teaching someone a private exam, because we often neglect that. We actually treat the dummy as a dummy and we describe the patient as a dummy as well. But the most important things are the dignity of the patient, the privacy of the patient, if the patient is comfortable, and documenting all the events that happen during the consultation. So that for now is the two teaching cases. Do you guys have any questions at all in these? These are really basic, simple teaching cases, nothing complicated, very easy, doable, and you can score really good if you're engaging with the patient and you're natural. Any questions?
Okay, so Dr. Aisha, thank you for the teaching.
You're welcome.
Hello.
Yeah.
All right. So, if the patient has any pain, that means you can continue the teaching. I mean, sorry, the examination.
Well, in the exam, it's a dummy, right? But you have to tell the patient that if the patient is in pain, you should avoid without pain medication. Of course, if someone is in pain, how can you do a PV? You're inserting a duct speculum and causing more pain. I would never do that.
Okay. All
Yeah.
right. Thank you.
Yeah. Also remember that for PV exam, there are no contraindications. The contraindications are for cervical smear, like if you're pregnant or you had sex or you used any spermicidal gel, and I've forgotten the fourth one.
Menstrual period.
Sorry?
When the patient is on a menstruation for cervical smear.
No. For cervical smear, there are 4 contraindications. Like you can't do it if they're pregnant. You can't do it if they are menstruating. You can't do it if they've had sex or if they have used a spermicidal gel. These are the 4 contraindications when you cannot do cervical smear, but they are not contraindications for pelvic examination. So you can do a pelvic exam easily. Except in pain, you shouldn't do it when a patient is in pain. Any questions? Any other questions, or should we call it off?
Thank you, Dr. Aisha, for the amazing session. I just wanted to ask that you taught us how to teach a student how to do the speculum examination, but do we also need to teach them how to do take a cervical smear?
No,
Thank
no.
you.
If it's mentioned that it's a smear test, then you only teach them a smear. If it's mentioned PV, you teach them PV.
Thank you.
Okay, everyone. I am not sure if I'll be able to upload this video to YouTube, but I've recorded it and I hope that I can upload it to YouTube, but probably not over the weekend. It's going to take me time. That's about it. Take care and until next time. Bye bye.
Thank you, doctor.
Anytime. Bye.
Bye. Thank you.
Thank you.